I'm Jackie Travis. My PCOT question was, in sedentary adults with newly diagnosed type 2 diabetes, is initiating an exercise program more effective at reducing hemoglobin A1C than oral hypoglycemic agents over a 3-month period? As I began doing my research, I was surprised and dismayed to find that there was very little research to answer this specific question. I was only able to find one study that got close to answering it, but otherwise ended up using studies that found that exercise was beneficial in patients who were at risk of developing or already had a diagnosis of type 2 diabetes. The study that came close to answering my question was done by Knoller for the New England Journal of Medicine. It sought to determine whether intensive lifestyle interventions were more effective than metformin at preventing the development of type 2 diabetes in at-risk patients. There were over 3,000 participants randomly assigned to 3 groups for this study: a placebo group, a metformin group, and a lifestyle modification group. Both the placebo and metformin groups got standard lifestyle recommendations in addition to either a placebo or metformin twice daily. For the lifestyle modification group, they set a goal for 7% weight loss, and interventions included 150 minutes of exercise per week and a 16-lesson individualized curriculum taught by case managers to teach participants about diet, exercise, and behavior modification. Knoller found that the lifestyle intervention and metformin groups both had reduced the incidence of developing type 2 diabetes, but the lifestyle intervention group had a 58% decreased incidence compared to a 31% decreased incidence in the metformin group. Another study by Balducci, published in the journal Diabetes Care, measured the effects of supervised exercise on the adverse effects of insulin therapy, such as weight gain and extended or systemic inflammation, in overweight patients with type 2 diabetes. Balducci and his team split participants into 2 groups. The control group received only exercise counseling, while the intervention group received counseling in addition to 75 minutes of supervised aerobic and resistance training twice a week. By the end of the study, the exercise group clocked significantly more exercise time and showed improvements in hemoglobin A1C, waist circumference, blood pressure, CRP, LDL, and overall coronary heart disease risk factors. In a study in the Canadian Journal of Cardiology led by Pandy, measured the effects of burst exercise on hemoglobin A1C in patients with newly diagnosed type 2 diabetes over a 3-month period. Those in the control group were asked to do 30 minutes of sustained moderate intensity exercise 5 times weekly, with moderate intensity being defined as 60% of maximal heart rate. The participants in the burst exercise group performed 10-minute sessions of high-intensity exercise 3 times a day, 5 days per week, with high intensity being 85% of maximal heart rate. After a 3-month period, the burst exercise group reported more minutes of exercise per month, had greater improvements in aerobic fitness, a greater decrease in BMI, and had a 4 to 10% reduction in hemoglobin A1C compared to an approximately 3% reduction in the control group. The burst exercise group also had greater reductions in triglyceride and LDL levels and a greater increase in HDL levels. According to the American Diabetic Association, there are over 30 million people in the United States with diabetes, with 1.5 million cases being diagnosed each year, which tells me something about what we are doing isn't working, and I think it shows in our practice. We see these patients on a daily basis, often when they are suffering as a result of complications of type 2 diabetes, such as after an MI, stroke, or leg amputation. When I ask my patients how they are managing their diabetes, it almost exclusively includes oral hypoglycemic agents, insulin, or both. It is exceedingly rare that they say they manage it with diet or exercise, and my question is why? I think a good place to start to address this problem is to gather more information from the patients themselves to find out what the barriers are. Did their doctor even present the option of exercise as a potential intervention before starting medication? Are they not open to change at this point in their lives? Do they feel like medication is more convenient? Do they feel like they don't have time to exercise? Do they not want to exercise? Do they think they have to go to a gym and spend a lot of money in order to get an effective workout? Do they have a physical limitation? There are a variety of reasons people make the decisions they do, but our job is to make sure they are truly able to make a fully informed decision, and that starts with talking to our patients, meeting them where they're at, and finding out what we as providers could be doing better. A lot of this information could be gathered from a simple, anonymous questionnaire for the patients with type 2 diabetes, with agreement from the patient to do a follow-up survey after a designated length of time. The survey could be handed out when they visit their primary care provider, at community health and public events, and even during a hospitalization, particularly if the patient is at a teaching or research hospital. Once the most common barriers have been determined, we could come up with a list of resources for these patients and provide them with information on how to overcome the barriers of their specific situation if they are open to change. These resources could be made available in several places, such as hospital education databases, community health websites, and businesses and doctors' offices. Another option would be to make a simple infographic sheet or poster board that includes information about the impact of exercise and present it at events such as fundraisers, especially ones that benefit diabetic organizations. We could then do the follow-up survey to see if patients were exposed to the resources, ended up using them, implemented any of the recommended changes, and ask why or why not. An option to reach a larger group of people at one time would be to do a class in places like diabetic clinics and provide a survey at the beginning of the class to assess what the patients already know about the topic to be presented, and a survey at the end of class to assess what they have learned, how likely they are to implement changes, share information with the others or recommend the class, and whether they would be interested in attending another class. If patients report that their providers did not recommend lifestyle modifications first, it would require going directly to the source and find out from providers why they made the recommendation they did. Possibilities may include that they themselves lack information about the research, do not feel comfortable making those recommendations because of a lack of knowledge, feel like they do not have the time to properly counsel patients, or that there is a financial benefit to writing a prescription. Again, there could be several reasons for their decisions, but in order to truly benefit our patients, we have to be willing and able to discuss all options with them and provide the pros and cons of all those options. Although making these kinds of changes to the current standard of medicating for type 2 diabetes seems like it could be difficult when working as an inpatient nurse, as many of us do, it is certainly not impossible. We spend more time with our patients than anyone else on their care team and are often the most trusted, and hearing from us could be more beneficial and meaningful for the patient than, say, being nagged by a spouse to make changes. If we could even take a few minutes to talk with patients about how big of an influence lifestyle has on type 2 diabetes, not to mention a multitude of other diagnoses, it could have a huge impact on the health of our patients and our country. Not only could it positively impact overall health, it could help drastically decrease the amount of money we spend as a country on chronic disease. According to the website fightchronicdisease.org, we currently spend $1.65 trillion treating patients with more than one chronic disease. The top 7 chronic diseases account for 1.3 trillion of that and could increase to 6 trillion by the year 2050. It could be as simple as including information in their discharge paperwork if they aren't in a place where they're open to a discussion at that specific point in time, or it could include a more in-depth conversation about changes to make and suggestions for how to make them. Sometimes all they need is to hear this information from one person to get the ball rolling, and we have the opportunity to be that person for them every time we walk into work. Thank you for watching.